Welcome to the video lecture for Unit 2, Module 4.2. In this one, we're going to talk about the cardiac conducting system. As always, here are your learning objectives. Be sure to reference these when working on your lecture quiz as well as the unit exam. Let's jump into it. So in a single cardiac contraction or heartbeat, the entire heart contracts in a series, first the atria and then the ventricles. Two types of cardiac muscle cells are involved in a normal heartbeat. One, specialized muscle cells of the conducting system control and coordinate the heartbeat. And two, contractile cells produce the powerful contractions that propel blood. Each heartbeat begins with an action potential generated at a pacemaker called the SA node, which is part of the conducting system. The conducting system then propagates and distributes this electrical impulse to stimulate contractile cells to push the blood in the right direction at the proper time. A procedure known as an electrocardiography can monitor the electrical events of the conducting system from the surface of the body. The printed record of the results is called an electrocardiogram, or EKG, ECG, whichever terminology you use there. The arrival of an electrical impulse at a cardiac muscle cell's plasma membrane produces an action potential that is comparable to an action potential in a skeletal muscle fiber. As in skeletal muscle fibers, this action potential triggers the contraction of the cardiac muscle cell. Thanks to the coordination that's provided by the conducting system, the atria contract first, driving blood into the ventricles through the AV valves, and the ventricles contract next, driving blood out of the heart through the semilunar valves. The SA node generates impulses at regular intervals, and one heartbeat follows another throughout your life. After each heartbeat comes a brief pause, less than a half a second or so, before the next heartbeat begins. The period from start of one heartbeat to the start of the next is called the cardiac cycle. A heartbeat lasts only about 370 milliseconds. Although brief, it is a very busy period. So we're going to look at following the steps that produce a single heartbeat from the generation of an action potential at the SA node through the contractions at the atria and the ventricles. So unlike skeletal muscles, cardiac muscle tissue contracts on its own without neural or hormonal stimulation, and this property is called automaticity or autorhythmicity. The cells that initiate and distribute the stimulus to contract are part of the heart's conducting system, also known as the cardiac conduction system or the nodal system. This system is a network of specialized cardiac muscle cells that initiates and distributes electrical impulses. The actual contraction lags behind the beginning of an electrical impulse, or the action potential. The delay comes from time it takes calcium ions to enter the sarcoplasm and activate the contraction process. The atrioventricular node, located at the junction between the atria and the ventricles. Conducting cells interconnect the two nodes and distribute the contractile stimulus to the myocardium. In the atria, conducting cells are found in internodal pathways, which distribute the contractile stimulus to atrial muscle cells, as this electrical impulse travels from the SA node to the AV node. The importance of these pathways in relating to the signal of the AV node remains in dispute because at an impulse, it can also spread from contractile cell to contractile cell, reaching the AV node about the same time as the impulse travels at an internodal pathway. In the ventricles, conducting cells include those in the AV bundle and the bundle branches, as well as the Purkinje fibers, which distribute the stimulus to the ventricular myocardium. Most of the cells of the conducting system are smaller than the contractile cells of the myocardium and contain very few myofibrils. Purkinje cells, however, are much larger in diameter than the contractile cells. As a result, they conduct action potentials much more quickly than other conducting cells. Conducting cells of the SA and the AV node share a special characteristic. Their excitable membranes do not have a stable resting potential. Each time it repolarizes, the membrane then drifts towards threshold. This gradual depolarization is called a prepotential or a pacemaker potential. The prepotential results from a slow inflow of sodium without a compensating outflow of potassium. The rate of spontaneous depolarization differs in various parts of the conducting system. It is fastest at the SA node. Without neural or hormonal stimulation, the SA node generates action potentials at a rate of about 80 to 100 per minute. Isolated cells of the AV node depolarize more slowly, generating about 40 to 60 action potentials per minute. Because the SA node reaches threshold first, it establishes the heart rate. In other words, the impulse generated by the SA node brings the AV nodal cells to threshold faster than does the prepotential of the AV nodal cells. The normal resting heart rate is somewhat slower than 80 to 100 beats per minute. However, due to the effects of the parasympathetic innervation, if SA node or any of the other atrial pathway becomes damaged, the heart continues to beat, but a slower rate, usually 40 to 60 beats per minute, as dictated by the AV node. Certain cells in the Purkinje fiber network depolarize spontaneously at an even slower rate. If the rest of the conducting system is damaged, these cells can stimulate the heart rate of 20 to 40 beats per minute. Under normal conditions, cells of the AV bundle, the bundle branches, and most Purkinje fibers do not depolarize simultaneously. If, due to damage or disease, these cells do begin depolarizing spontaneously, the heart may no longer pump blood effectively. Death can result if the problem persists. Now let's trace the path of an impulse from its initiation at the SA node, examining its effects of the surrounding myocardium as we proceed. So the SA node is embedded in the posterior wall of the right atrium, near the entrance of the superior vena cava. The SA node contains pacemaker cells, which establish the heart rate. As a result, the SA node is known as the cardiac pacemaker or the natural pacemaker. The SA node is connected to the larger AV node by the internodal pathways in the atrial walls. An action potential takes approximately 50 milliseconds to travel from the SA node to the AV node along these pathways. Along the way, the conducting cells pass the stimulus to contractile cells of both the atria. The action potential then spreads across the atrial surfaces by cell-to-cell contact. The stimulus affects only the atria because the cardiac skeleton isolates the atrial myocardium from the ventricular myocardium. The relatively large atrioventricular node sits within the floor of the right atrium near the opening of the coronary sinus. The impulse slows as it leaves the internodal pathway and enters the AV node, because the nodal cells are smaller in diameter than the conducting cells. In addition, the connections between nodal cells are less efficient than those between conducting cells at relaying the impulse from one cell to another. As a result, the impulse takes about 100 milliseconds to pass to the AV node. This delay is important because it allows the atria to contract before the ventricles do. Otherwise, contraction of the powerful ventricles would close the AV valves and prevent blood flow from the atria to the ventricles. After this brief delay, the impulse is conducted along the atrioventricular bundle, and the bundle branches to the Purkinje fibers and the papillary muscles. The Purkinje fibers then distribute the impulse to the ventricular myocardium, and the ventricular contraction begins. The cells of the AV node can conduct impulses at a maximum rate of 230 per minute. Because each impulse results in a ventricular contraction, this value is the maximum normal heart rate. Even if the SA node generates impulse at a faster rate, the ventricles will still contract at 230 beats per minute. This limitation is important because mechanical factors, which we'll talk about later, begin to decrease the pumping efficiency of the heart rates above approximately 180 beats per minute. Rates above 230 occur only when the heart or the conducting system has been damaged or stimulated by drugs. As ventricular rates increase towards their theoretical maximum limits of 300 to 400 beats per minute, pumping effectiveness becomes dangerously, if not fatally, reduced. A number of clinical problems result from abnormal pacemaker function. Bradycardia is a condition where the heart rate is slower than normal, and tachycardia is a faster than normal heart rate. These terms are relative, and in clinical practice, the definitions vary within the normal resting heart rate of the individual. Most of the time in a clinical setting, you'll hear someone as being tachy, it's meaning their heart rate's fast. The connection between the AV node and the AV bundle, also called the bundle of His, is normally the only electrical connection between the atria and the ventricles. Once an impulse enters the AV bundle, it travels into the interventricular septum and enters the right and left bundle branches. The left bundle branch, which supplies the massive left ventricle, is much larger than the right bundle branch. Both branches extend towards the apex of the heart, turn, and fan out deep to the endocardial surface. As the branches diverge, they conduct the impulse to the Purkinje fibers, throughout the moderator band, to the papillary muscles of the right ventricle. Purkinje fibers conduct action potentials very rapidly, as fast as small myelinated axons. Within about 75 milliseconds, the signal to begin a contraction has reached all the ventricular cardiac muscle cells. By this time, the atria have completed their contractions and the ventricular contractions can safely occur. The entire process, from the generation of an impulse at the SA node to the complete depolarization of the ventricular myocardium, normally takes around 225 milliseconds. Because the bundle branches deliver the impulse across the moderator band to the papillary muscles directly, rather than by way of Purkinje fibers, the papillary muscles begin contracting before the rest of the ventricular musculature does. Contraction of the papillary muscles applies tension to the chordae tendineae, bracing the AV valves. By limiting the movement of the cusps, tension in the chordae tendineae prevents the backflow of blood into the atria when the ventricles contract. The Purkinje fibers radiate from the apex towards the base of the heart. As a result, the ventricles contract in a wave that begins the apex and spreads towards the base. The contraction pushes blood towards the base of the heart, into the aorta and the pulmonary trunk. Damage to the conducting pathways disturbs the normal rhythm of the heart. The resulting problems are called conduction deficits. If the SA node or the internodal pathways are damaged, the AV node assumes command. The heart continues beating normally, but at a slower rate. If an abnormal conducting cell or ventricular muscle cell begins generating action potentials at a higher rate, the impulses can override those of the SA or the AV node. The origin of these abnormal symbols is called an ectopic pacemaker. The activity of an ectopic pacemaker partially or completely bypasses the conducting system, disrupting the timing of ventricular contraction. The result may be a dangerous reduction in the pumping efficiency of the heart. Such conditions are commonly diagnosed with the aids of an electrocardiogram. The electrical events in the heart are powerful enough to be detected by electrodes on the surface of the body. A recording of these events is an electrocardiogram, also called an ECG or EKG. Each time the heart beats, a wave of depolarization spreads to the atria, pauses at the AV node, then travels down the interventricular septum to the apex, turns, and then spreads to the ventricular myocardium towards the base. An EKG integrates electrical information from electrodes placed at different locations on the body surface. Clinicians can use an EKG to assess the performance of specific nodal conducting and contractile components. When a portion of the heart has been damaged by heart attack, for example, the EKG reveals an abnormal pattern of impulse conduction. The appearance of the EKG varies with placement of the monitoring electrodes or leads. Note the following EKG features. The small P wave, which accompanies the depolarization of the atria. And the atria begin contracting about 25 milliseconds after the start of the P wave. The QRS complex, which appears as the ventricles depolarize. This electrical signal is relatively strong because the ventricular muscle is much more massive than that of the atria. It is also a complex signal, largely because of the complex pathway that spreads of depolarization takes through the ventricles. The ventricles begin contracting shortly after the peak of the R wave. The smaller T wave, which indicates ventricular repolarization. Atrial repolarization is not apparent because it takes place while the ventricles are depolarizing, and the QRS complex masks the electrical events. To analyze an EKG, you must measure the size of the voltage changes and determine the durations and the temporal relationships of the various components. The amount of depolarization during the P wave and the QRS complex is particularly important in making a diagnosis. For example, an excessively large QRS complex often indicates that the heart has become enlarged. A smaller than normal electrical signal may mean that the mass of the heart muscle has decreased, although monitoring problems are more often responsible. The size and shape of the T wave may also be affected by any condition that slows ventricular repolarization. For example, starvation and low cardiac energy reserves, or coronary ischemia, or an abnormal ion concentration reduce the size of the T wave. The times between the waves are reported as segments and intervals. Segments generally extend from the end of one wave to the start of another. Intervals are more variable, but always include at least one entire wave. The names, however, can be somewhat misleading. For example, the PR interval extends from the start of the atrial depolarization to the start of the QRS complex, ventricular depolarization, rather than to R because in abnormal EKGs, the peak at R can be difficult to determine. Extension of the PR interval to more than 200 milliseconds can indicate damage to the conducting pathways of the AV node. The QT interval indicates the time required for the ventricles to undergo a single cycle of depolarization and repolarization. It's usually measured from end of the PR wave interval rather than from the bottom of the Q wave. The QT interval can be lengthened by electrolyte disturbances, some medications, conducting problems, coronary ischemia, or myocardial damage. A congenital heart defect that can cause sudden death without warning may be detectable as a prolonged QT interval. An arrhythmia is an irregularity in the normal rhythm or the force of the heartbeat. Serious arrhythmias may indicate damage to the myocardium, injuries to the pacemakers or conducting pathways, exposure to drugs, or abnormalities in the electrolyte composition of extracellular fluids. The Purkinje fibers distribute the stimulus to the contractile cells, which form the bulk of the atrial and ventricular walls. These cells account for about 99% of the muscle cells in the heart. In both cardiac muscle cells and skeletal muscle fibers, an action potential leads to the appearance of calcium along the myofibrils, and two, the binding of calcium to troponin on the thin filaments indicates that the contraction. But skeletal and cardiac muscle cells differ in terms of nature and action potential, the source of the calcium, and the duration of the resting contraction. The resting potential of a ventricular contractile cell is approximately minus 90 millivolts, compared to that of resting skeletal muscle fibers around minus 85 millivolts. The resting potential of an atrium, or described here, applies to the atrial cells as well. The exponential begins when the membrane of the ventricular muscle cells reaches threshold, usually about minus 70 to minus 75 millivolts. Threshold is normally reached in a portion of the membrane next to an intercalated disc. The typical stimulus is the excitation of an adjacent muscle cell. Once threshold has been reached, the exponential proceeds in three basic steps. 1. Rapid depolarization. The stage of rapid depolarization in cardiac muscle cell resembles that in skeletal muscle fibers. At threshold, voltage-gated sodium channels open and the membrane suddenly becomes permeable to sodium. A massive influx of sodium ions rapidly depolarizes the sarcolemma. The channels involved are called fast sodium channels because they open quickly and remain open for only a few milliseconds. 2. The plateau. As the membrane potential approaches positive 130 millivolts, the voltage-gated sodium channels close. They remain closed and inactivated until the membrane potential drops to minus 60 millivolts. The cell now begins actively pumping sodium out of the cell. However, a net loss of positive charge does not continue, because as the sodium channels are closing, voltage-gated potassium or calcium channels are opening. These channels are called slow calcium channels because they open slowly and remain open for a relatively long period, roughly 175 milliseconds or so. While the slow calcium channels are open, calcium ions enter the cytosol. The entry of positive charges to the calcium channel in the form of calcium roughly balances the loss of positive ions to the active transport of sodium. And the membrane potential remains near 0 millivolts for an extended period. This portion of the exponential curve is called the plateau. The presence of a plateau is the major difference between the exponentials in cardiac muscle cells and in skeletal muscle fibers. In skeletal muscle fibers, rapid depolarization is immediately followed by rapid repolarization. And 3, repolarization. As the plateau continues, slow calcium channels begin closing and slow potassium channels begin opening. As these channels open, potassium ions rush out of the cell, and the net result is a period of rapid repolarization that restores the resting potential. As with skeletal muscle contractions, the membrane will not respond normally to a second stimulus for some time after an action potential begins. This time is called the refractory period. Initially, the absolute refractory period, which is where the membrane cannot respond at all, because the sodium channels are either already open or closed and inactivated. In a ventricular muscle cell, the absolute refractory period lasts approximately 200 milliseconds. It includes the plateau and the initial period of rapid repolarization. The absolute refractory period is followed by a shorter, 50 milliseconds or so, relative refractory period. During this period, the voltage-gated sodium channels are closed, but they can open. The membrane will respond to a stronger than normal stimulus by initiating another action potential. In total, an action potential in a ventricular contractile cell lasts about 250 to 300 milliseconds, about 30 times as long as a typical action potential in skeletal muscle fiber. The appearance of an action potential in the cardiac muscle plasma membrane produces a contraction by causing an increase in the contraction of calcium around the myofibrils. This process takes place in 2 steps. 1. Calcium ions crossing the plasma membrane during the plateau phase of the action potential provide roughly 20% of the calcium required for a contraction. 2. The arrival of this extracellular calcium triggers the release of additional calcium from reserves in the sarcoplasmic reticulum. Extracellular calcium ions thus have both direct and indirect effects on cardiac muscle cell contraction. For this reason, cardiac muscle tissue is highly sensitive to changes in cardiac contraction or in calcium concentrations of the extracellular fluid. In a skeletal muscle fiber, the action potential is relatively brief and ends as the resulting twitch contraction begins. The twitch contraction is short and ends as the sarcoplasmic reticulum reclaims the calcium it released. In cardiac muscle cells, as we have seen, the action potential is prolonged and calcium ions continue to enter the cell through the plateau. As a result, the muscle cell actively contracts until the plateau ends. As the slow calcium channels close, the intracellular calcium ions are absorbed by the sarcoplasmic reticulum or are pumped out of the cell, and the muscle cells relaxes. In skeletal muscle fibers, the refractory period ends before peak tension develops. As a result, twitches can summate and tetanus can occur. In cardiac muscle cells, the absolute refractory period continues until relaxation is underway. Because summation is not possible, tetanic contractions cannot occur in a normal cardiac muscle cell, regardless of any frequency or intensity of stimulation. This feature is vital. A heart in tetany could not pump blood. With a single twitch lasting 250 milliseconds or longer, a normal cardiac muscle cell could reach 300 to 400 contractions per minute under maximum stimulation. This rate is not reached in a normal heart due to limitations imposed by the conducting system. When a normal heart is beating, it gets energy as the mitochondria break down fatty acids, or stored lipid droplets, and glucose, stored as glycogen. These aerobic reactions can occur only when oxygen is readily available. In addition to obtaining oxygen from the coronary circulation, cardiac muscle cells maintain their own sizable reserves of oxygen. In these cells, oxygen molecules are bound to the heme units of myoglobin molecules. Normally, the combination of circulatory supplies plus myoglobin reserves is enough to meet the oxygen demand of the heart, even when it is working at maximum capacity.